to introduce Dr. Oscar Guillamondegui. He's an extremely busy trauma surgeon, and actually at dinner last night I was shocked to hear the volumes of trauma that he deals with in a day. So very active clinical surgeon, has been super active in quality improvement. In fact, he was the vice chair of surgical quality, safety, and professionalism, which is part of the whole package there at Vanderbilt, and he's also the director of the Trauma ICU as well. So we're extremely delighted to have Oscar. I was telling him that our collaborative actually exists in part based on the work that they had done in Tennessee. So they've had a collaborative there for quite some time, made some amazing improvements, and based on their successes, we were able to bring our case forward to the ministry. So thank you, Oscar. I really appreciate you being here today, and we're looking forward to hearing from you.
It's a real pleasure and an honor to be here. Tim has done a lot of work to get you guys to this point. I know because I started out the Tennessee Surgical Quality Collaborative on the back of a napkin with two of my mentors through the Tennessee American College of Surgeons state group. We were sitting around kind of talking about it, and it went from a napkin to a reality over the course of about 18 months. And I want to take you on the journey of where that took us as a collaborative. And I think it'll hopefully inspire you guys. You already are inspired. You're in the room. You're doing all the work. But this is a taste of what we did across the course of the last 10 years or so. And I'm a fidgeter, so I can't stand still. That's why I had to put the mic on. So I'll kind of go through the big picture stuff, and then I'm going to drop it down to the hospital level and even the surgeon-specific level, which is a little difficult with NSQIP data because there's only a few cases per surgeon, so it makes it a little bit harder to get actual statistically positive data on people. Our collaborative started out with 3 major hospitals, and then it moved to this consortium with the help of our Tennessee Hospital Association. And our desire, we started with the Michigan Collaborative. We went to this thing thinking we wanted to have a back and forth with just the surgeons and Blue Cross Blue Shield. We ended up with the Tennessee Hospital Association becoming our major data dumper, the place where we got our administration from, and they hold all our data because they're a statewide entity. They cover all the hospitals. It made it really easy to get information exchange across that. And it's really, the most important part was that at the time that we were looking to make our collaborative, it was everything happens because of fate. And in this case, the head of the patient Center for Patient Safety was looking for a new project, a pet project to take on. And we walked in the door of their institution literally minutes after she was asked to find another task, and we stepped right into it. So luck comes from hard work and then some luck. And our aim, of course, was to improve the outcomes of the people in Tennessee, and we wanted it to be, in our case, kind of surgeon-driven as opposed to administration-driven, and that's where we shot for the target. And this, as you guys know, and what happened within our own state, became this incredible voice for change at the grassroots level. And what I hope I show you is that from that grassroots level, you can make powerful change for your patient population and for your institution, and actually probably for the product. So whenever you do something like this, and I'm sure Tim probably could say the same, first you have to come up with a cool logo, right? So we got a cool logo, and then we developed our mission statement, and then we developed a vision statement. All those things become really important. And then we had the perfect storm of the 10 hospitals across this thin state that made up, at the time, probably 50% of the operative volume within Tennessee. So not quite to the level of being statistically able to say we cover all of it. You have to get to 80% to say that you can speak for the outcomes of an entire group. But 50%, pretty good. And those are the original 10 hospitals spread out across the state. And then we added 22, there was the new 11, and then one hospital that wasn't part of NSQIP but wanted to be part of the data stream joined in just because they saw how powerful it was. And by the time we did that, we achieved 80% of the entire operative volume in hospitals, not in captured NSQIP, but in hospitals across the state. Our state has 7 million people, so what's Ontario total? About the same. So it's pretty impressive that just through 22 hospitals we can cover all of that. And here they are. And for some reason, every time I fix this slide, it still pushes St. Thomas Midtown's number and Region 1 Health over. But these are the amount of beds in each of these hospitals. They range everywhere from 85 beds in a county hospital in Claiborne, Tennessee, which is in the middle of nowhere, and it touches 5 counties that don't have a hospital. So this 24-bed hospital, the one surgeon from that hospital, I'm going to show you how powerful one surgeon can be by the end of this, touches the lives of like an incredible amount of people in an area. All the way up to Vanderbilt, which is where I work, which has a 1,000-bed hospital. It's now up to 1,200. So we have 5 hospitals that are small, 7 hospitals that are pretty big, 6 university hospitals, and at this point now it's 80% of the operative volume. Pretty impressive group. And we all come together like this, and nobody throws daggers. Everybody's kind of on board. We still have not de-identified the sites because Vanderbilt won't let that happen. You know, when you're a giant corporation, sometimes you don't want other people to know all of your dirty laundry, even though most of it gets out in the news. But the most important impetus to make this project work was getting the surgeon champions involved. And to do that, we forced the surgeon champions to have to present and be a part of the collaborative. Because if they're not engaged, then you don't have a voice, and if you don't have a voice, even if it comes from every other aspect, if the surgeon's voice isn't heard locally, then you can't change the culture locally. So it becomes really important. So these are just some of the people in our group that all got up and went to their institutions about various topics, which you can see here. It gets skin in the game. It's a viable product to the home institution, and it understands the data. It makes you have to understand what that data is and how it represents your institution, your outcome. And one of the things that I learned really early on was knowing the definitions of each aspect of that data point. Because if you don't know the differences in some of the subtle differences in some of the data points, as opposed to what you might hear from the CDC or from some other organization, you can't sit at the table and have a conversation. So this is, we have this incredible data analyst. His name is Bill Cecil. He worked for Blue Cross Blue Shield for many years. And if you know anything about actuarial data, it's billions upon billions of data points. And so the ability to manipulate that data to somebody that's been working with billions of data points becomes pretty easy when it's just a couple 100,000. But one of the things that any major insurance agency that has a large volume of patients that they've been following for 40, 50, 60, 80, 100 years, in all honesty, they could probably predict every single person in this room's outcome just based on where you are right now. And they don't do it. This is our data from the start through 2014 of what happened to our postoperative occurrences and our zeroing of postoperative occurrences. And so over the course of 5 years, we really pushed that number through the roof. And that was one of the first things that we identified. And if you look at postoperative occurrences, that number shot 30% improvement. And my first thought about that, across the spectrum of all the institutions, is that it's really a Hawthorne effect. No one was taking a look at the data. No one really cared. My father was a head and neck surgeon. He was a pretty good guy. I sit around the table with him now, and he says he was the best head and neck surgeon at MD Anderson. And I said, well, how do you know? He says, because I know what my outcomes were. I said, well, what were they? Well, I don't have any data, but I know my patients did better. Thanks, Dad. Show me the data should be the answer every time. Right? We have the data, and what makes it so powerful is that if you look at something, I'll get into SSIs, but if you look at the data, there was an institution in the United States that published that the deep space infections for colorectal surgery were 5 to 7% at their institution. And they have multiple papers saying that. But if you look at the NSQIP data, that number was somewhere around 17 to 18% 10 years ago. And so I kept thinking, if this hospital is 3 times better than every other place in the United States, why don't they build a 5,000 bed hospital, put every colorectal case there, and make sure that they get the best possible care they can get in the world? Turns out that it's all about bias of the data. And if you don't hold to the integrity of the data, you have a selection bias in the patients that you put into your studies, and you always look good because you never want to look bad. So what I love about a collaborative is if you come to the table and you say, we are bad, we start from the presupposition in this institution that we're in right here, a first sin, then you can only get better when you have some kind of anointing. And this is the mortality rate. And we showed the first 10 hospitals that just by doing what we were coming together and talking about things, we were dropping our mortality rate over the same period. And it keeps trending down. Now, if you look at the original papers that came out of the VA, and then out of the first few years of the NSQIP beta sites, they showed a 46% reduction in mortality. But what happens after that? It levels out. And the same thing was true for morbidity. It didn't, it was all almost an initial event, and then it stopped happening. So that's what I worried about when we started Collaborative. And were we just seeing that Hawthorne effect, that initial push that we're going to do all these initial things and nothing else is going to change. I'm going to show you that it continues to get better, hopefully. So this is our surgical site rates. This is the way that we presented it by our entire group. I know there's a lot of busy slides. All you need to know the arrows are going down. And so over the course of multiple years, whether it was organ space, superficial, all SSIs, they went down based upon simple techniques that were kind of shared amongst the groups, not as a major push. And if you look at this, the risk-adjusted rates continue to climb down, but not at the level that our observed rates did, right? So once you took out all the patients that had thyroidectomies that never get a site inspection, and you match them up with the people that had colorectal surgery, then the rate isn't quite as good, and it doesn't stay quite as downward trending, but it's still present. So there are times that you're going to see that there is no change in your data, even when you make changes to the system, and I think that's okay. And one of the reasons why I say that is that we followed the trends of, I think it's pneumonia, or deaths in England and Wales for a 15-year period, and you see that there are variations in deaths and across the flus, whatever seasonal things happen, whatever the case may be, I don't know. But whatever that is, there are going to be changes in outcomes at different times. And if you don't believe that that could happen, then you're going to miss the boat that you could still be trending down even though you have upward spikes, right? So don't give up because it's going the wrong direction. And this is what happened if we looked at observed mortality rates and then we looked at them based on age. You can see that even though our observed and our trend are down, even with age, there's a little bit of upticks at time and downticks. And we think that that also has to do with times of the year. For the elderly, fall risks are higher at certain times of the year, different times of the year for motor vehicle crashes, and we kind of follow those trends, and you can see that jagged line remains for almost all of our data. This is a crazy slide. This is Bill Cecil throwing spaghetti at a wall and seeing something sticks. And what he's not a clinician, does not have any knowledge of what is clinically relevant or not. But what he did do was he looked at our Tennessee Surgical Quality Collaborative, every single one of the outcomes over there. Every one of them, from death to acute kidney injury. And then he put them through the outcomes financial generator that the college has and showed what the cost savings were based upon our reduction in each one of these outcomes. And if you look at this number down here, over the course of just 4 years, we saved the state of Tennessee patient population and insurance companies $31 million. And that's a thumbnail just on the cases that we saw. Not the ones in the penumbra, the patients that aren't in NSQIP that have the same outcome difference, right? Because just because it's only 1,600 patients in your hospital that you're capturing or whatever your number is, there's all the other cases around that also get the benefit of what we bring to the table with our data. So this is a very conservative measure. And if you take that back to the ministry, there's no way they won't continue to fund it, right? This is the kind of data that you have to cell in order to show the work. And this is real dollars. It's not fake dollars. What we did was we looked at each site and we started doing this checkerboard grid. Green means you're okay. Red means you're doing worse than you did the previous 6 months. Blue means you're doing better. And so if you look across this thing, you can see most of the centers are doing about the same across time frames. That's fine. It's okay to not see change. But you can see the one that's really red. When you look at this, this is all of the various outcomes, and this is how we did. And we checkerboarded all these so that you can actually see over a trend where you sit in the collaborative. And there's some places that have good outcomes, some that have bad. And what we started to do was take those good outcome people and marry them up with the bad outcome people and say, why don't you go take a look? Go see what they're doing at that good center and what they're doing at the bad center. Is there something tangible that you can just garner just from going and seeing what they're doing? Not setting up some protocol, not setting up something new or different, just going and saying, what is it that those guys are doing that Guillamondegui's shop isn't doing? And so if you follow that, we have it, comparing risk across year to year. You can see trends, and then it just continues when you look at across sites, all the performances. We just kind of show this data over and over and over again, and you can see that at certain times there are benefits, sometimes there's not. And like in this one, site R, which is second line, has a lower patient risk for total postoperative occurrences. And then G has a really bad outcome for total postoperative occurrences. And if you take those two hospitals and bring them together, they can maybe come up with something that changes their outcomes. And for me, this was eye-opening because I knew we were site W and I knew that where we stood, and I could kind of look around the room and go, who can I talk to about this stuff and take it back to my institution? So then we start looking at kind of various aspects. And our network follow-up meetings after these kind of initial checkerboard thing. If you look at this, this is all procedures observed versus predicted in time. And we started looking at how different centers had different operative times for the same procedures. And you could see that offset. And it doesn't matter whether you look at laparoscopic appendectomies or at cholecystectomies, there was a predicted operative time and there was an observed operative time. And one of the things that you have to kind of wade through shark-infested waters with on data like this is what it represents. Because if you unmask all of this data, here's colectomies. What you almost will find to a T is that the teaching institutions push your operative times down the Y or the x-axis. So you walk a fine line in some of the political realms as to what you want people to comprehend from the data. If you say teaching hospitals are causing longer operative times, well, here's the sad part about that. The longer the operative time, the more complications you have, right? And this is the y-axis is where 0 hits down here, and you can see that the longer that your laparoscopic surgical cholecystectomy is, the more your risk of having a bad outcome, some postoperative occurrence. It starts at 0. But what we also noted, it started at 0 at appendectomy. But what was really interesting is that it started before the case in colectomy. So what you start to realize is that postoperative occurrences may be based on something other than just the operative care, right? There's pre-care issues. We call it prehabilitation. What is it about that colectomy patient that's different from the appy patient or the cholecystectomy patient? And you start scratching your head and you start trying to think of what are the things that we could change or do that could make that, that bar drive down towards 0 hour at the time of start. Smoking, nutritional status, functional status when they came through the door, all the different things that we know that you capture in that NSQIP data set that can define what these issues are. It's really impressive stuff. But the fact that they started before the case even started was a eureka moment for us. Because as everyone's saying, look at your data, you've got crummy outcomes, look at this. Then you start looking at the procedures and you realize there's inherent risk to doing surgery that started with the patient before they came to you. So then you can say, all right, we're never going to get to zero, but our drive should be to get as low as we possibly can. And in comparing that data with each other, what you say is, I'm going to drop my guard, and I'm going to get rid of this kind of perfectionist model, right? When you live in a perfectionist model, the only thing you can do is fail, because we've never achieved perfection. And when we get to that point, it's all about shaming, and we want to avoid that. Because once you put up the wall of shame, you lose the ability to have a discussion about change, because now you're defensive, and we don't want to do that. So within an organization that has the ability to talk to each other, this is the moment where you realize we can affect change without being mean to each other by saying I'm better than you. We all say we're getting there at the same time. And this was kind of our risk-adjusted model of operative site by site. So there were certain centers that were in the red, which were worse. There were certain centers that were in the blue, which were better. And guess what? All of the red sites were teaching institutions. All the blue sites were really nice hospitals with marble walls and fountains and stuff. But think about this. If you're at that marble-walled hospital, somebody comes in and they don't look like they're the right fit for your outcomes, what do? You say, that's a good teaching case. You send them off to the teaching hospital. So there are differences in the cases that are taken care of, at least in the United States, I can't speak for Canada, and who gets taken care of where. And that becomes a real rat trap. Yes, ma'am?
Doesn't NSQIP adjust for those?
It can, but it's kind of hard. I've talked to Cliff Coe and to Mark Cohen, who runs all they're still not able to capture 100% of the model differences, right? They can't. And it sits at about 80%, just like the area under the curve. About 80% is what you can achieve. If you can get to above 80%, you're doing great. But that wiggle room, that 20% wiggle room is where you see this difference. It's not much, it's just a little. So then we start looking at outcomes from new to old centers, because we brought these other centers in. We said maybe there's something that's going to, the reason why we continue to get better is because the old centers have stopped, and now the new centers are making us look good. So we looked at that data. It turns out if you looked at sepsis by site, they were flat. You look at SSIs by site, they're flat. So our drive down is still coming from those original hospitals. And the reason why they're flat is that there were a lot of high-performing centers that didn't have a lot of room to give because they already had people that were doing the things they were doing with a population of patients that probably wasn't quite as sick as the ones that were at the other hospitals. And here you see one for incisional. Theirs went up, but it's diurnal trend. Ours is still going down. The blue is old, the green is new. Here's organ space. No real change across those. And if you talk to the surgeons of those institutions, we have a couple of surgeons that haven't had a surgical site infection and colectomy in years. Years. And they're honest about the data. I can't believe it, but it's true. We can't go a week without swinging a dead cat and hitting at least 5 people with an organ space infection. And I'll show you why towards the end of this talk. And here's pneumonia, it's the same thing. Here's UTI, it's going down a little bit. But if you started looking at comparison of old to new, and you look across all of the odds ratios for all these different things, what we find is that if you looked at new versus old, their risk was lower than the original group, right? So we're showing that trend. For the expected operative time, new were shorter already than the old because we captured all of the teaching hospitals in the first group, but the private hospitals in the second group didn't have as much room to give. And if you looked at this is one, I love saying this to people. This is a really busy slide. So why did I put it up there? Because what it's showing is that what we did was we looked at every type of procedure that was being done. And in the red, it shows that they were, that the old sites were worse, and the blue shows that the old sites were better, and it's all the things that you expect versus colectomy versus pancreatectomy, and those kind of things where the high volume is at the high volume centers that do them, the low volume is at the ones that have worse outcomes in those things. Okay, so then we start saying, are we really affecting change? So really, have we done anything other than just kind of muddy the waters? And here we go. If you looked at the post-operative occurrences for prevalence of enterectomy, we showed that if you adjust across all small intestine resection, that mortality, organ space, sepsis, superficial, and UTI improved, right? So we're showing, even after years of data, that we're still getting improvement. Here's one for just for colectomy. It shows that sepsis is better, but nothing else was changed. So that's because the centers that had the great outcomes were still having great outcomes. They've driven the outcomes better in the old center. Here's no change for cholecystectomy. It's what you expect. It's a kind of a chip shot operation. We shouldn't see much change from busy centers, no matter what they are, if you're doing them all. And it showed the same in our data, right? And here's another one for inguinal hernia repair. No real change, right? So you start getting the bread and butter procedures, and there's no real difference. It turns out that there are variable procedures that are going to have variable outcomes, and if you focus on those, you end up affecting change more than if you put your efforts into something that you're not going to get anything out of. Long runs for short slides. Here's one for colectomy. We showed that mortality, all the stuff was improved with the care that we're giving changes, right? So now what? We decided that colons were the problem, right? And so we went forward with a task group of about 5 people. They went out to train on what was good, and they came up with a simple plan. You can't make it complex. The more moving parts, the harder it is to implement, and you have less ability to change that. So they went and grabbed all this data, and the most important aspect of this was the last line here. They wanted it to be cheap, because you can't go back to hospitals that don't have any margin and tell them they got to spend a lot of money to make it better. So all they did was went for 4 simple things: normothermia, glucose control, appropriate antibiotic use, and supplemental antibiotics. We didn't even say they had to do the ERAS protocols and all that stuff. That came later. But if you look at this data, what we showed was that historically our group was the worst high outlier in the country. That's a feat. It's hard to take that back to my boss every SAR. So here we are, the next SAR, still the highest group in the country. Still the highest. Are we doing anything that's making a difference? Well, you know the data is 6 months in arrears, so you're just barely catching the culture in 1 year of doing this, right? Uh-oh. It's starting to drop. And here we are, then 2 years after the start date, and we've fallen to the 3rd decile. So showing that this stuff works, and here we are again. We've remained that way. We stay within the 3 to 8, which is where you kind of want to be, doesn't matter. And here we were at the start. I don't know if I have the secondary one, but that's how bad we were. We're the 3rd worst hospital in the world, I think. But at least we're beating the University of Michigan. I don't know why they call it an honor roll. It seems kind of bad. Anyway, so then you start looking, well, what's the difference? Because now I have to talk to my administration, and they want to know, should we do NHSN, should we do NSQIP? And you have to know the difference between what data source you're using, but they all trend down, right? So the blue line is NSQIP, the red line is NHSN. NHSN captures every colorectal case, whether it's a OB-GYN hitting the colon on the way in or the way out versus, trauma doing that, whereas NSQIP doesn't keep transplant, trauma, or OB in there, or unless you do OB. So the difference is that the numbers may look different. It may have a slightly different trend, but it usually goes in the same direction. So if you look at what we did in the 5-year summary of that period, we decreased 20% almost in post-operative occurrences. 9 out of 17 of the post-operative occurrences were significantly decreased. We had 3.75 deaths per 1,000 reduced in the state of Tennessee. And then we saved about $75 million worth of care. That's powerful stuff to take back. And the same thing's going to happen here. So we then took a study design, looked at all this stuff, and this is where we showed, let's kind of flip through this, what's the difference, what do we have in the post-operative outcomes, regression models, blah, blah, blah. And then we looked at the long procedures versus the short procedures, and we showed that no matter what you do, if you have a case that goes about 2.5 hours, that's your sweet spot. And every second outside of that point, your risk for post-operative occurrences goes up. Now I know what you're saying. Yeah, well, I was doing a Whipple, and it also invaded the colon, and then we had this, and we had that, and it had to go through the portal vein, blah, blah, blah. Sure. But if you're doing a simple case and you say, well, it's because it was harder, there's all sorts of reasons why that happens. It doesn't matter. The longer your case goes, the the higher your risk for postoperative occurrences. And it didn't matter if you're doing an appy or you're doing a colectomy. So the shorter you can make it, and we have so many surgeons that I've watched that they just go in there and they look like a bear tearing up a beehive, just ripping through it. And then like at 30 minutes, they're putting something back together and you're like, okay, and they get out, no complications. You see somebody that's like meticulous and has like their special long handle this and that, and the scissors are gold and all that, and they take 3 hours over, but oh, look how beautiful it looks, and that person ends up with much more of occurrences. We do have our faults. But there are things that you can do to kind of look at the procedures and say, what is it that we're doing differently? And maybe make some changes around that too. So if you broke it down, the results showed that no matter what the categories were, that we had changes. And the marginal time risk, if you look, it was 14 minutes for the marginal time risk for APIs, 6 minutes for deep space, 14 minutes for organ, it just depended. If you looked across all clean procedures, it was about that same mean time. And it just kind of spreads out after that. Kind of cool stuff. But that's what you can do with big data. That's what you can do with big data. And you can do it better than the college can do it because you know each other, you know what you're looking for, and the college has to be generic about how they go at it. Doesn't mean that they couldn't do it, but they just have so many moving parts that they can't help every single person identify the one thing that they want to look at, right? So we saw that correlated time was not new. The biggest problem is the challenge to the residency programs, and so that kind of makes it a tightrope walk. And then the unique findings were when the time risk occurred, which was before surgery, and that the rate of the risk for selected postoperative occurrences, and then how do you customize it to each of your surgeons, and that's how you can kind of work through all that data. And then, of course, the utility was that it was our data. It was all our data within our state, within our friends, within our community, so we could talk about it more. And finally, we owe professional responsibility to improve that data over time. Okay, so does it always work? Because we're on a roll. All projects have succeeded so far. What are we going to do next? Well, we decided that, look at this, you have our general vascular morbidity was better, our colorectal SSIs were driven through the floor, we had no real difference, but a little bit better in the UTIs. So then we said, hey, we've got all these things, we've done colorectal, I didn't show you our ERAS because it's too long, and now let's look at pneumonia. So look at this, here's our pneumonia problem. In the state of Tennessee, we were already worse by 50%, and Vanderbilt was even worse than that. So we've got opportunity. This is another opportunity. So what do? We said, holy crap, look at our values. When I went to the administration, I said, hey, we've got a pneumonia problem, but wait, it's okay. It's a little bit better than it was last time. So when you sell it, you got to sell it right. So I said, although it's bad, it's better than it was, so they don't yell at me that much. And this is also true for all cases of VTE. So we said that here's the definition, this is what we're defining it as, and we're going to look at it in the NSQIP data, and then we showed that if you look at, this is my institution, but if you look at the growth of the emergency general surgery program, it's taken up another 10% than what it did when we first started, and it turns out that most, I think I've got it slide, these are the emergency cases by volume, it's grown, part of it due to definition because we're already still doing it, but if you looked at it, it wasn't the ventilator-associated pneumonias. Those we captured, those were getting better because we have all these things to do for ventilator-associated pneumonias. It was the non-ventilator-associated pneumonias. And guess what population that occurred in? It occurred in the emergency general surgery cases that were dumped on our hospital. We're not supposed to say dumped. That were given to our hospital to take care of these challenging cases. And in the post-operative setting, they developed pulmonary complications. Now, what makes that really difficult? You can't get to them before surgery, right? So we looked at all these pulmonary complications. We talked about all the different measures. These were the things that we were already doing within our institution. We knew that PS11 was a big deal for CMS, which is our Medicare group, and we already provided surveillance through NSQIP on the non-intubated patients. Perfect place to start. ICOUGH, right? So now my good friend Dave McEnany from Boston has come up with this. When he showed me the data initially, I said, that is not a JAMA article. There's no way that's going to be a JAMA article, and look where it is. It's in JAMA. It's amazing. So it was so simple. It was such an easy process. I'm like, this cannot work. And it turns out, if you put this into a nutshell, It's nursing care. Just taking care of the everyday stuff that we don't do anymore because everybody's too busy to do it, right? It says spirometry, cough and debrief, oral care, understanding patient education. And so that starts in the clinic, head of bed elevation, post-operative pain control. So here we go. We're on a roll. We're going to roll this out. I'm going to make this happen in my institution. We went to a workshop, talked to the guys at Boston, brought them in, went to our 9 North unit, which is where all of our post-op colectomies go from the colorectal guys and from emergency surgery. And look what happened when we did our audits. 30% had bed elevation, 38% ambulating, 50% IS in room, 46 were using it, they're close enough for them to garner. Uh-oh. Fail. Fail. First time ever, a project we rolled out failed. Why did it fail? Well, it turns out that all these things are centered around patient education, and the successful program begins in the clinic, continues to the perioperative phase, monitored, and then there's home care post-discharge stuff. Well, I went and did a project bundle analysis for this, because it never should have failed. It turns out when you look at all these things, there's 3 aspects of the bundle. The first is people on the top, organization in the middle, learning systems at the bottom, and it's, is there a leadership commitment? Is there a dedicated team? Is there a champion? Do they align with the institutional goals? Is there a policy in place to make this work? Model for interventions and planning, resources for the teams to do it, and then finally, what's our surveillance tool? What's our process to review data, and our multi-level training? Well, if you get a score of higher than 2.4, you're going to succeed. If it's less than 1.8, you're going to fail, and we were at 1.3. We never had a chance because there was no leadership commitment. There was no dedicated team, and there was no champion. I can't do that. I can't do it today. I couldn't do it then. I can't be everywhere at all places at all time. So what do? I went back to the institution. I said, let's find a leadership commitment. Let's get one of our dedicated team members and a champion. And I pulled my safety officers that I run through my quality program and said, you're going to do it. And you're going to be capable of doing it. And we're going to give you the tool set to do it. And we went up to 2.4, high likelihood of success, just by putting those right things in place. So now let's see what happened. We partnered with our institutional patient care center. We designated a manager from the administration side. We allowed the champions to find the work group to make it work. I put it on them, not on me. And then 3 months turnaround, 6 months today, that's what we wanted to do. So here's what happened. If you look at the TSQC pneumonia rates, this is our average. We sit at 1.46, a little bit of a high outlier. And there are 9 programs that need improvement. And there's only one exemplary program right here, 0.35, the best performer in the country. Guess who that was? Not Vanderbilt. But it was the Claiborne County Hospital, where they got complete buy-in from every member of the team, initiated the program in full, and within 6 months had driven their rate to the lowest in the country. So it works, and we know it works. But we failed because we didn't have the institutional commitment, and I didn't have champions. So you have to take it to that level institutionally. All the big talk in the world isn't going to get you there. So then you look at what's happening in pneumonia. This is our institution, and even though we just started re-rolling it out, we're already on the downward trend from what was once a big uptick. So if you'll give me a few minutes, I don't want to take too much of your time here. So surgeon-specific data, and how can you get good with this, and what are the opportunities? We have all these different opportunities to really reduce outcomes, and all the different stuff that we have at our fingertips. So what we did was we did some surgeon-specific modeling within the institution, and this is a lot of data to basically say that we're looking at relative risk of outcomes for each surgeon. And you have to have enough procedures in this to do that. And what we did was we looked at this relative risk model, which is observed the number of cases to expected number of cases, and we showed that 7% of the group were exemplars. 7% of the people in the surgical collaborative were really good surgeons, and then 2% were outliers. And it gave us this graph, which shows all the green are in the mean. They're all people that, even though it kind of goes high, these people have relative adjustments that make them normal. There's a few red and a few blue. A few red are bad, a few blue are good. I think this will show you. Yeah. So if you looked at the data, in the first set we had 27 exemplars, 7 outliers out of a total 394 surgeons. And in the second period, we go back, now we have 18 exemplars, 10 outliers, and there are only a couple that were the same in both groups. One bad outlier who no longer practiced the surgery, and the 3 good outliers, but everyone else resorbs to the mean. And what that tells me is that we have bad weeks and we have good weeks. And every once in a while you have a rash of cases that go bad and you're like, I didn't do anything differently, but something happens, so you can't always hold on to the fact that somebody that looks bad today is going to look bad tomorrow. So you've got to trend it out. But it's pretty cool data to show that we as surgeons who always think that you walk into a room and you have to say, oh, I'm better than him, I'm worse than him, oh, I know I'm definitely better than that gal, I'm better than, you know, she's better than me. But it turns out we're all pretty much equal. And once you get rid of that, comparison, which, by the way, comparison is a thief of joy. You know, you take away that comparison, and you now have the opportunity to have a conversation so that we're all okay. Now let's move forward. And there it is, showing the difference of the next time around. This is our risk-adjusted operative time. Same kind of thing falls out. You have some exemplars, you have some outliers, but they always resorb to the mean every 6 months. And if you look at this, this is my Vanderbilt data. So we went from the whole TSQC to Vanderbilt data. What we did was we have 6 groups of general surgeons: EGS, emergency surgeon, colorectal, hepatobiliary, GI, vascular, and endo. And this is the mean preoperative risk score for each of them. So you can see the EGS patients are really sick. The colorectal are semi-sick. The hepatobiliary fairly, still sick. And then the other guys are all not in practice. So what we did was we plotted this out on a graph. And we showed in our institution the various groups. So all the 6 groups, you can see this corner over there is worse than expected. This is better than expected. But anything within these 2 other arms are normal. That's mean expected outcome. And you can see EGS is sick, occurrence of severity up, patient risk up. As you go down, it goes to easier on both sides. But bad group head. Now, what happens if you explode all of the surgeons? Even within groups, you can see that they fall out all over the board. There's a few kind of worse than expected. There's a few better than expected. That's me. Of course. I don't know. I don't know if it's really me, but I thought it was funny. No, it is really me. But this is how we did it. And what we did was we showed this data to each of our surgeons so they could see where they sat on a curve. And you know that when you do that to surgeons, they all want to get better. Well, they want to know who that other guy is, so they can feed them down and do worse, which is bad. But anyway, the answer, of course, for all this is that you want to show data that's real, that has meaningful impact to your people. Locally, statewide, nationally, however you want to do it. Here's some really interesting data. This is the PARS data. This is our data on patient complaints to surgeons at Vanderbilt. So randomly, people call and say, Guillamondegui is a jerk. And they put a mark next to that. And then Guillamondegui is a jerk. The next day, oh God, that was 2 for me and 1 for him. And they keep doing that. And they follow these, and they show that for every single event that somebody calls you a jerk or says you did bad care, there's 50 to 80 more complaints behind that aren't voiced by the patients. So when you take complaints and you look at wound occurrences, so various outcomes, if you take this data and you have simple cases, it doesn't matter, you're always going to be okay in terms of occurrences. Simple cases, all okay. The higher the complexity across the x-axis, if you're a low complaint person versus a high complaint person, you can see what happens to the outcomes. The people that get complained about more have worse outcomes. That's powerful data. The reason for that could be multifocal. I can't tell you exactly why, because it's not matched one-to-one case to the outcome, but it's data of complaints to things. So when the cases are easy, everybody does okay. When the cases are hard, it gets worse. And this is what we found. If you look in the OR, you go into the OR, and you're sitting there. We had med students go in the OR and sit. All they do was observe. The room's getting ready. You got the scrub nurse, you got the scrub techs, you got the anesthesia techs. Everybody's kind of setting up their stuff, and they're listening to music. It's all rocking, everything's great. And then the surgeon walks in the room. Either everything keeps on jazzing around, everybody's kind of, hey, what's up? Or you got the room that goes completely silent. And it turns out that there are things that happen in rooms because of the stress level and the amount of fear And I'll be out, just give me 2 seconds, almost done. And so it turns out that there are people that are good and people that are bad, and if you keep a light, loose room, people tend to do better. But if you're the guy that throws the gold-handled scissors across the room, and then the scrub nurse has to go out and go find another pair, they may spend another 10 minutes out there talking to the person in the core saying, "Yeah, Guillamondegui, jerk, I'm not going back in there for a while." And you're sitting around waiting to do your case, so your time extends on the cases, right? So you're pushing out length of case because of passive-aggressive behavior. Maybe that's it. I don't know. We can get to that later. But anyway, what it showed, if you look overall at what we did within this collaborative, we drove down a lot of things. We saved lives, we saved outcomes, we pushed the costs avoided, and each one of these things, no matter how you distill it, I don't care if you look at our last 15 years and say 75%, 75 million, or you look at 1 year and you say 5 million. It doesn't matter. The fact is that what you're doing in this room and in this collaborative is changing the face of surgical care within your community. And that is powerful stuff. So what I love most is the culture change. It's about mutual respect. It's about taking the ideas from any source that you can get them and putting them together to get to a better outcome. And an honest exchange of failures. It's not always going to be a success, and we build character when we fail, not when we succeed. So doing that is going to make you a better organization to admit the faults and fix them as opposed to cover them up. One of my least favorite things about NSQIP was that initially they numbered the hospitals from 1 to whatever to X. And so my first talk that I ever gave at NSQIP was on the fact that the first 12 hospitals, when they said that they should all, you should get better because of NSQIP. So then I marched out the first 12 hospitals over the course of like 4 years, and they went all over the map. Some years they were good, some years they were bad, and I contended that if you're telling me that NSQIP is so great that we should all tumble into the first quartile by 2 years because we're all doing the right thing. Turns out the patients aren't that simple. There's complexities of care that are going to change that, so you have to be aware of that change, that diurnal change, those ups and downs are going to occur, whether you're looking at total deaths in Wales or you're looking at the amount of morbidity or mortality you're having in your own institution. Remember to trust the data. You've got to get surgeons to trust the data. My chief of surgery, when I first showed him the data, said, "I don't believe in NSQIP data." I said, "Well, okay, there's 800 hospitals in NSQIP and they all believe the data. You're the one guy that thinks that we're doing the wrong model? All right, we'll go with that." Then clarity of focus. Find things that you can work on that are going to be powerful and have an outcome difference. If there's not much variability, you're going to have a lot of run for a short slide. And that's, you need to find the places where you can make change that will be variably better. And then finally, I think it's all about being non-punitive and celebrating as a group what's both good and bad within the organization. And with that, I thank you. I can't tell you how much of a pleasure it is to be here. Even though it's rainy, it's okay. This is a beautiful city, and I'm happy to come and help you out a little bit.